So I'm Joyce Graff. I'm with the Powerful Patient, and welcome today. We're going to talk about a very interesting condition that has a name, but I'm going to tell you first about the symptoms that it causes, because if you bruise easily, if you bleed a lot, like you have nosebleeds or heavy periods, if when you stand up you feel like you might fall over or you might faint or that your heart is racing, we're going to talk with you today about a condition that you should consider talking with your doctor about. And we have an expert with us, Dr. Blair Grubb from the University of Toledo. He's the director of clinical cardiac electrophysiology there and is one of the world's authorities on the treatment of syncope, which is the abrupt or brief loss of consciousness, and other disorders of the autonomic nervous system. That's that automatic regulation system in all our bodies that's supposed to make sure that everything goes well when you change positions or when some emergency is happening, but we don't usually consciously affect those systems. They're supposed to happen automatically. Sometimes things don't go quite so well. So welcome, Dr. Grubb, and we're interested to talk with you about this fascinating condition.
Um, to understand what's going on and put the symptoms in context, first you have to realize that, as you mentioned, the autonomic system is what runs the stuff you don't think about. So there are two aspects to the human nervous system. One's called somatic, that's the part you have control, and then autonomic, which is the part you don't. So when a person stands, gravity will displace downward roughly 1/3 of the body's blood volume, and that displacement will occur almost immediately. And so the human body must react to that. Otherwise, everybody would come close to passing out or pass out whenever they stood. Humans are the most gravitationally challenged animals on the planet. We're the only ones who really walk on two legs and are upright. And so our brain is the furthest away from our center of gravity proportionate to body size of any animal on Earth. So when you stand and gravity displaces blood downward, your brain must sense that and then must react quickly. And the way it reacts is it tells your heart to beat faster, tells it to beat more forcibly. But the major thing is it will tell the vasculature in the lower half of the body to become 3 times tighter than what it was. And that sudden tightening will push blood upwards towards the head. And it'll occur immediately. So the normal individual can easily jump out of bed, jump out of a chair, do double backflips if they want to, and the pressure system will automatically regulate and keep everything fine. However, at times it doesn't work, like every other part of the human body. And in some individuals, and we're still working on all the reasons why, the body will lose the ability to maintain the tightness of the vasculature. And that when that happens, when you stand, gravity will displace downward a disproportionate amount of blood to the lower half of you. How you feel then will be dependent on how much extra blood is displaced downward and how rapidly that occurs. If it's a small amount, you'll just kind of feel tired. But if it's more, you'll feel like you can't think, can't focus, can't concentrate. More still, you'll start to get lightheaded, dizzy. More still, you'll see black spots, get tunnel vision. More still, you'll pass out. And oftentimes, now the whole system can fail or parts of the system can fail. And in younger people, what usually happens is the ability to vasoconstrict fails, but the other aspects may stay intact. And so when you stand and gravity pulls blood downward, the brain doesn't realize why things aren't working, and so tries to compensate by telling your heart to beat harder and faster. And so when the person stands, they'll suddenly feel their heart beating much more forcibly, beating much harder, and then they will continue to get many of these symptoms. Unfortunately, that mechanism evolved in animals to compensate for dehydration. So in the human, when your heart starts getting in this condition, when your heart starts beating much, much faster, it'll hit a point where it actually is becoming a less and less efficient pump. The heart can only pump the blood it receives. If a lot of the blood is sitting in the lower half of you, going faster isn't going to help. And as
Mm.
it gets faster and faster and faster, the filling time in between each beat declines. And so the actual output of blood by the heart begins to decline as well. And so the compensatory mechanism actually becomes part of the pathophysiology. This is identical to what happens in congestive heart failure. In congestive heart failure, you lose a different part of that triad I mentioned. You lose contractility. And so the body thinks it's dehydrated and starts to vasoconstrict and increase heart rate. And so in congestive heart failure, it's those compensations that become part of the pathophysiology as well. And those become targets for us to alter when we're treating people.
So I understand that this can be brought on by certain events, like puberty is one of them. So both for men and women, it can be brought on by puberty or pregnancy. Sometimes if you've had a big blood loss. But one of the interesting ones is that if you have a viral infection, like for example, COVID, that this can also cause this to start up. Is that true?
Yes, about our data is about 70% of patients that we see will describe an antecedent febrile illness that we presume was viral, that precedes the development of their symptoms. And the time frame, it varies, but it's usually within the first weeks or months or so afterward. And this is the mechanism behind many autoimmune conditions. And the way a virus gets into you is by looking kind of like you. Otherwise, it would be immediately recognized and destroyed. After it gets in, your immune system, after a while, will notice it's there and begin to make antibodies to identify it so that T cells and B cells can then destroy it. But unfortunately, in some people, the antibody response is somewhat imperfect, and it goes after anything that resembles that virus, including the parts of you it was able to disguise itself as looking like. And so this concept is called molecular mimicry. And so then your own system begins to attack itself. This is a common observed mechanism. For example, in type 1 diabetes, there's a viral infection usually in a child that precedes the development of diabetes. In my own wife, she got a bad viral infection and several weeks later developed full-blown rheumatoid arthritis. So this is a well-known mechanism. This molecular mimicry idea is a well-known mechanism for the triggering of autoimmune conditions. And it's usually people who somehow are genetically predisposed in some way. And you'll oftentimes hear of autoimmune conditions running in families, that there will be a real tendency. Now, the autoimmune disease itself may be very different from person to person, but just the fact that your immune system is failing to recognize parts of you as you can run in families. But at the same time, the incidence of all autoimmune disorders is increasing dramatically all over the Western world. And it is unclear why. One of the leading theories is that we're too clean, that humans evolved with parasites and things that your immune system was constantly fighting. And we only have eliminated parasites in the Western world over the last 100 or so years. That's a relatively brief time, and our immune systems, which are used to constantly fighting against multiple parasitic infections, suddenly become hypersensitive to little changes within us and begin to attack us. So the incidence of Crohn's disease is increasing. The incidence of multiple sclerosis is increasing. The incidence of rheumatoid arthritis, all of these conditions are becoming more frequent in our society. So it's as if we've traded one set of problems for a different set of problems.
Interesting. I know in the early days of COVID, it seemed that Africa and India were having a lighter course with it than us in the Western world. It wasn't until the Delta variant that we seemed to be getting terrible infections in India and Africa.
Well, COVID's actually been somewhat of a stimulus to our work in a way, because COVID is also a type of viral infection, and in about anywhere between 30 and 50% of patients who have COVID infections will develop long-term symptoms, what they call long-haul COVID patients. And a number of these are later diagnosed as having postural tachycardia syndrome or one of the autonomic disorders. So we are just starting a study where we're going to be looking at those individuals. Now, as an addition to what I said previously, so we who were researching POTS and other autonomic disorders felt for a very long time that there was a strong possibility that these were autoimmune in nature. Unfortunately, the technology was not advanced enough to really pursue that in a practical way. These isolations and all were extremely time consuming and expensive, and so people just didn't do it. However, about a little more than a decade ago, a number of new technologies became available that made this now a practical thing to start to look at. And so we and other groups began to look more intensely to see if we could identify autoantibodies that could be causative in nature. In our first study, we published a paper where we found close to 90% of patients had a autoantibody to what are called alpha-1 receptors, and these are in vascular smooth muscle, and they're also in the GI tract. And so if they govern tightening of blood vessels, so if something is blocking their function, blood vessels would stay loose and wouldn't tighten, which is exactly what we see. At the same time, if they occupy receptors in the bowels, it would cause bowel hypomotility because of the fact that these govern motility in the bowel or peristalsis. Subsequently, groups in at the University of Oklahoma have found similar things. A group in Lund, Sweden has found that using a very different technique has found the same sort of thing. So we're pretty sure we're on the right path. Unfortunately, the COVID infection, COVID pandemic, caused many universities to put their research programs on hold, and we were one of them. And so since April of last year, we've been on hold, and only a few weeks ago have we been able to resume our research, and we just are now enrolling people. Mm-hmm. The human immune, we've also realized several other things. The human immune system has two components to it. One is called innate immunity and the other is called adaptive. The innate immune system you are born with, and that system principally uses mast cells, eosinophils, basophils, and a group of compounds called interleukins to defend you. And then the adaptive immune system, the one we're a little more used to thinking about, uses antibodies, T cells, and B cells. And those T cells and B cells are referred to as killer cells. So the antibody latches onto something, and then the T cells and B cells come along to get it. So about 50 years ago, a gentleman named Rose, a physician named Rose at the Johns Hopkins Hospital, first proposed that the adaptive immune system could turn against you. And he was quite criticized, and people thought, no, how can your own immune system turn against you? And he persisted despite skepticism, and now we all accept the fact that that happens. And so the term autoimmune is reserved to describe when your adaptive immune system is turning against you. Okay. About 10 to 15 years ago, it was realized that the innate immune system may also turn against you. And the term autoinflammatory disorder has become popular to describe that. We strongly suspected that there was an autoinflammatory component. Now, many illnesses, such as adult rheumatoid arthritis, seem to have an autoinflammatory initial component followed by an autoimmune, it triggers an autoimmune state that then continues. In the COVID patients, the cytokine storm that they have during their initial infection appears mediated by the innate immune system, therefore is an autoinflammatory response. And then in anywhere between 30 and 50% of those survivors, it will initiate a long-term autoimmune response. So the one can trigger the other. We suspected that there was an autoinflammatory component because of the fact that many patients had mast cell disorders. Many of the children that we would see would have eosinophilic esophagitis or invasion of the stomach with eosinophils, suggesting that there was this autoinflammatory component going on as well. And we published a paper showing that the interleukin levels and cytokine levels within our patients were extraordinarily high. We have a paper with matched controls that we're just getting ready to submit for publication, that shows that these levels are sometimes 50 times higher in patients. So what the picture is beginning to evolve is that we may be dealing in many patients with a condition that very closely resembles the immunology that's seen in, say, rheumatoid arthritis, where you have a viral infection that first stimulates a autoinflammatory state and then can trigger an autoimmune state that'll be persistent. Now, as I mentioned, we're behind our targets because of the pandemic, and everything was on hold. And we're now going back to it, except we modified our research protocol in that we will be looking not only at post-viral POTS patients and controls, but we will also be looking at post-COVID long haul patients with POTS to see if we can identify the same autoantibodies. And we just started, so I can't give you any update.
Sure. That's fascinating. So my colleague, Robin Martinez, is on the line as well. Robin is the chief moderator for smartpatients.com. And there are many people there who are seeking a diagnosis or who have one of these very tricky diseases that are not easy to diagnose. So Robin, what do you hear from your autoimmune patients about POTS and related problems?
The people who have autoimmune syndromes know that once you have one autoimmune syndrome, the likelihood that you're going to get more is very high. So we have people who have 6 or 8 autoimmune syndromes going on at the same time. The symptoms overlap. It gets very confusing for diagnosis. Sometimes they don't get in for diagnosis until they've already developed like 6 conditions. And the doctor that they talk to says, "You're too complicated, go away." Or "You have a mental problem." Nobody has that much wrong with them. So this is a very, very difficult area to get a diagnosis in, and a difficult area for patients to cope with. But one of the problems that we see a lot, especially with Sjogren's syndrome, is that the autoantibodies that mark the syndrome don't show up until years after the symptoms have gotten really bad. So people go in and they say, "I have these 18 symptoms," and the doctor says, "Well, let's give you a test." The test comes back negative, and they say, "No, you don't have Sjogren's syndrome," even though clinically the diagnosis clearly points to it. So my question about POTS, because we have lots of people who've got POTS developing or going on right now, how soon do the autoantibodies get to a measurable level?
We don't know that yet. That'll be something we'll have to look at, and there may be other ones involved as well. I mean, the cost of doing this stuff is extremely high. We spent close to $100,000 so far in doing this research, and so we had to choose carefully which autoantibodies we were looking for, and we chose 9 that we could easily measure. This stuff has to be custom made for us and stuff, so it's very costly, and we chose 9 culprit ones that seemed to be the most likely. And we found, as I said, 90% of the people had these alpha 1. They were variable points in time after the initiation of the illness. So again, I can't tell you that. At the same time, we did also find that 50% of patients had high levels of 50% of those who were alpha 1 positive had autoantibodies to what are called muscarinic M4 receptors. Now, the problem there is we don't understand what they do well. they are in the brain heavily, and they govern dopamine release, and they're particularly highly concentrated in the basal ganglia of the brain. But they're in other areas as well. And so, again, I don't know what role they may be playing, or if they're playing a role. So all that is stuff we're going to have to work out. And we do, by the way, as you mentioned, frequently see people who develop additional autoimmune system problems, because if you think about it, if your immune system cannot recognize one aspect of you as you, it's not going to recognize others either. And sometimes, in these autoimmune conditions, the autoantibodies are against, say, a receptor that's in multiple areas of the body, not just one, or directed against a particular protein that's also in multiple areas of the body. So anywhere where that protein is, they will be affected by that condition. And so you can have multiple systems affected at the same time. So, I mean, and again, in rheumatology and in looking at autoimmune disorders, that's a fairly well established thing. I've had to learn a lot about rheumatoid arthritis, just because my wife suffers from it. And people don't realize that not only are your joints affected, but also your lungs, potentially your kidneys, your liver. I mean, as a matter of fact, on the scale of things, the joints are the least of your problems. And it's just that 100 years ago, when people were first describing this, all they could see were joints. They couldn't measure that other stuff. And so they focused on whatever they could see. There's a condition called scleroderma that affects skin, but the skin is the least of your worries. It destroys your lungs. So again, oftentimes these are multi-systemic in nature and affect all kinds of different things. Sometimes the same condition can have multiple antibodies that can do the damage. Again, rheumatoid arthritis, there are 2 major antibodies and probably more. Myasthenia gravis, there are 4 known autoantibodies and possibly more. Lupus, there are 10. So this is much more complex than we can fully grasp at present. But you start somewhere, and we just, we're going ahead and trying to work, as best we can.
So for someone who has symptoms like these and has hit that brick wall, you have too many problems, I don't know what to do, what kind of a doctor should they seek out to try to help them analyze the issue?
That's a very good question. I'm not sure I have a totally good answer for it. Unfortunately, modern American medicine has pretty much become like McDonald's and is a conveyor belt to just get you through as fast as possible. I mean, there are centers that specialize in autonomic disorders. There are also centers that specialize in difficult to uncover autoimmune conditions. But it can be very challenging for the patients to find those areas and have the resources to be able to get medical attention. So I don't have a good answer for that. I mean, and um, for a lot of people, a good internist should be able to start to figure this out, but unfortunately, that's often not the case.
So possibly a rheumatologist or someone who specializes in these kind of autoimmune diseases would likely have more listening for these kinds of problems.
One would hope.
Exactly.
Yes.
It's really frightening that a lot of people say, I'm on my 6th rheumatologist and I'm still not satisfied. Where do you find a good one? Where do you find one who's up on Sjogren's syndrome or lupus or something other than rheumatoid arthritis? Because rheumatoid arthritis and lupus are the 2 big common autoimmune syndromes that are fairly well known by rheumatologists, but there are lots and lots and lots of others that go under the radar. And a lot of the people with Sjogren's syndrome, which is a systemic disorder, are told, oh, it only affects your eyes and your mouth. Go away. It's very minor. Take this medicine.
Actually, 50% of Sjogren's patients will have autonomic involvement. So there's a huge overlap. And actually, studies have shown, remember I mentioned that we saw high levels of muscarinic M4 autoantibody, muscarinic M4 receptor autoantibodies. In Sjogren's, there's evidence to suggest that muscarinic M3 receptors are also targeted in the process. So there can be overlap there, between the two. And your immune system, as I said, once it can't recognize one part of you as you, it could stop recognizing other parts of you as you. And again, we frequently see people who have overlap conditions. As a matter of fact, one of the reasons we explored the relationship between autoimmune problems and POTS is so many people had concomitant autoimmune problems. So many people had a history of Hashimoto's thyroiditis, had a history of Crohn's, had a history of lupus, had a history of, psoriasis, had all kind of ankylosing spondylitis. Many of our patients have diagnosed comorbidities that we felt could not be just related to chance, that there had to be a link there. But again, I think one of the problems, I'm a cardiac electrophysiologist. I was initially trained as a surgeon. This has been a real learning experience, trying to wrap my head around all of the complexities of the immune system. Fortunately, my co-investigator, Dr. William Gunning, is an immunopathologist, so he's much more into this sort of thing. Indeed, one of his major achievements has been identifying a condition that's a bleeding disorder called granule storage disease, and those individuals, their platelets aren't constructed properly, and they act as if you're taking aspirin even if you're not. So they don't clump together well. They bleed, and we began to notice that many of our patients would complain of easy bruising, huge menstrual flow problems. They would use boxes of pads during their periods. They would have trouble with bleeding during surgery, and so we would investigate like coagulation profiles in these people. Because Dr. Gunning helped invent the test for delta granule storage disease, and because it's complicated and expensive to do, most institutions don't do it, and they just send the samples to some other place to do them. And so our institution gets samples from all over sent for Dr. Gunning to look for delta granule storage disease. And as part of our coagulation profile, we look at that, which other places don't do. And to our surprise, we oftentimes people were turning up positive, much more than one would assume, because initially they assumed this was a hereditary disorder that was not very common and only affected a few people. So we did a randomized trial looking at control subjects and our POTS patients, and we found that only about 5% of the control subjects had delta granule storage disease, which was what was estimated in the population, but 80% of our patients did. That's an immense difference. And it turns out, and again, this is all like the frontiers of human knowledge, that we did not realize until recently that the platelet is a major modulator of the human immune response in the innate immune system. So the platelet is a immunologic organ in a way. And we believe that this autoinflammatory process somewhat depletes the platelets of granules, makes them so they won't work, because every time we check for delta granule disease in patients, like 80% of the time it's positive. So that's a huge amount, and we're still struggling to wrap our heads around this. But it's becoming very, very evident in other research and other institutions that platelets play a major role in the immune response in a way that we fully don't understand.
A lot of people on Smart Patients have mentioned, our autoimmune communities have mentioned bleeding problems, unusual bruising when they didn't think they bumped anything, and nobody has been able to tell them what's going on.
It there are only a few centers in the United States that will do the test for delta granule storage disease because of the fact it requires doing electron microscopy of the platelets, and it's a very time and labor intensive test. And many people never even think to check for it. As a matter of fact, most physicians, I would confidently say most physicians have never heard of it. Um, and so if something you never look for is usually not found.
As COVID long haul syndrome becomes more prevalent, is there a medical specialty where that research is getting focused, or is that still somewhat dispersed?
It's very dispersed. I mean, the Johns Hopkins Hospital has a post-COVID clinic, a COVID long haul clinic, and I think Sinai in New York does. Um, we're trying to partner with a hospital in a program in New Jersey to look at the serum of post-COVID long haul patients with POTS to see if we can find the same autoantibodies. Post-COVID is in a state of evolution because it's only been like 15 months that this has been going on. So it's and people are at various stages of it, and but it's becoming a model for what we're seeing in our regular POTS patients. Except oftentimes you can get other aspects of things involved as well. Some of the ones I've seen have had terrible chronic lung problems from COVID infections. One particularly very unfortunate woman who was previously quite healthy now has to wear oxygen all the time. Has POTS symptoms, but on top of that also has horribly damaged lungs, and literally has to wear oxygen 24/7. She's only 50 some and was completely healthy previously. So again, we're going to have they're their own group, and we're going to have to tease out how this is playing out. There may be different antibodies that attack the lungs that are triggered, and it may be the same antibody that we're seeing in our regular POTS patients, or it may be different. I truly don't know yet. We're going to have to look. Albert Einstein once famously said, "If we knew what we were doing, it wouldn't be called research, would it?"
Oh, thank you so much. This has been wonderful. Robin, do you have any other questions for Dr. Grubb while we have his attention here?
No, I would only suggest that anybody who has or thinks they have an autoimmune syndrome contact smartpatients.com as a patient, because we have lots and lots of discussion about this, and you may find some help that you didn't know existed.
Yes, number one, know that you are not alone. There are other folks like you on the same journey. You are not crazy. You need to help, though, define your symptoms. Keep a log. I always suggest to people that they should keep a log. Don't go in and say, sometimes I have headaches. If you can say, regularly after I eat X, I have a headache or something like that. That really helps your doctor hone in on what the problem is. You are with your body 24 hours a day. The doctor sees you, 15 minutes once a month? So give him a break, give him as much data as he can to chew upon, and, help blend your personal experience with the vast experience of your physician. Partner up with that person and you will make progress, but sometimes it takes a lot of work.
Yeah, we have one person who reported recently that when she went in, she had a whole list of things to talk about, but she literally couldn't talk. She was having so much brain fog, and that's a very common symptom of the autoimmune syndromes. And the doctor says, well, you're developing dementia and you're cognitively impaired, and there's nothing I can do for you.
Yeah.
Interestingly, there is a growing body of research in neurology and psychiatry that suggests that depression in some people is an autoinflammatory disorder.
Hmm.
And we know that people can have these autoimmune encephalopathies where they develop psychosis and things like that. And so they're exploring a potential link between these inflammatory processes and different psychiatric problems, because they may be influencing each other as well.
Fascinating. Well, thank you so much for your very hard work on POTS and all these autoimmune disorders. It's wonderful to find someone who has taken on the challenge of delving as deeply as you have. So thank you very, very much.
You're very welcome.
And thanks to everybody who's listening in today. Be sure to check out smartpatients.com and other online places where you can find fellow travelers in your condition and try to assemble as much information as you can to work with your physicians to make progress on your condition. So thanks everybody, and I hope you have a great week and be well and be a powerful patient. Thank you.